Thank you very much for joining us today. Today we have 4 brilliant speakers to take part in the series that we've been running over the last couple of weeks. So 4 more great speakers to join our already brilliant speaker panel. I am going to be quite brief today because we want to be sure that you have time to listen to each of our presenters, and they're going to be speaking for about 10 minutes each. And then at the end, as Sandra just said, we will have time for questions. We are planning to take questions in any format you wish to give them to us. So use the chat, use the question and answer, or indeed put your hand up. And at the end, we'll have a little bit of time set aside to deal with all of your questions. You can also raise questions through or comments through the Twitter handles. And when we get to each of the speaker slides, you'll see their own personal Twitter handles. But if you wanted to comment across the series, use the Twitter hashtags that you see there. And these will be collated at the end of the series. You can see the dates and times there, and as Sandra said, this is the 4th of our series, and I'm delighted with how we're progressing. I would welcome feedback, so as we get towards the end of the series, we will be evaluating how it went, what worked well, what didn't work well, and really look forward to hearing your thoughts and comments on what we can do as we move forward. We are potentially looking at further series of webinars moving forward, so it'd be great to hear your comments. So, moving on. Today, I'll be setting the scene and doing a little introduction for each of the speakers. In terms of the content, I think I have a slow internet connection today. Today, we're going to be looking at a very brief look at the winning principles which have come out of the PEN Awards, and really each of these speakers will be brilliant examples of these winning principles in the framework that I'll show to you in a minute. But as I said, quite quickly we'll move on to our first speaker, which is Georgina from ELC, and she'll be looking at the Commissioning for Patient Experience. Then I will introduce Amy, who is from the Birmingham Women's NHS Foundation Trust, and she'll be looking at an app that they have been using for feedback. After Amy, we'll move on to Jenny, and Jenny is from United Lincolnshire Hospitals NHS Trust, and she'll be looking at something which is quite interesting, one of the few submissions around complaints and concerns. That'd be really interesting to hear from Jenny. And then finally, we'll wrap up with Heather from Public Health Wales and understand their work around their transgender awareness project. So as you can see, lots to cover, so I need to be brief. Why are we putting these speakers forward? Well, because they took part in the PEN Awards in 2014, and they were shortlisted as examples out of the very many submissions that were put forward as some of the examples that came to the top from the judges' perspective. So we wanted to give these shortlisted, these finalist organisations the opportunity to spread their best practice. And as part of the PEN Awards, everyone prepares a 10-minute presentation, and these are the presentations that you're going to see today. I think some people have updated them to make them current because this was back in March. So what we're going to be hearing is 10 minutes around their shortlisted, their winning, if you like, because everyone who takes part in the awards are winners, their examples of what was working well. When we actually look at the awards and the submissions, we've identified some winning principles, some principles that seem to be running through the majority, if not all, of the people who put forward their best practice. And as you might anticipate, there's no big surprises in here. And this I'm going to show to you very briefly today. Louise covered them in a lot more detail in last week's webinar, so if you'd like to learn a bit more about these, please go onto the website and hear what Louise said. Louise is the author of our Winning Principles report, which is also available on our website. So as you look at these, if you'd like to understand a little bit more about what they are, please do go and have a listen or have a look on our website. The website is www.patientexperiencernetwork.org, and it's under resources. So here you can see that intention and outlook is one of the key themes, and then critically you need to have the organisational support behind you to be able to enable you to deliver the excellence, and really importantly, we need to have management support. And today you'll see that the presentations all are great examples of how managers have supported the programmes as they've been put forward. And then the last theme is around evidence of impact. And as I said, I'm not going to cover these in a lot of detail today, but behind each of the 3 themes are 3 principles, and those are what are explored in more detail in the previous webinar. But today is about listening to our finalists, our winners from the Patient Experience Network Awards. And for questions, we've already covered that, but just to remind you, if you do have some questions, we'd absolutely love to hear from you. If you've got, don't assume that no one else is interested in your question. If you've got something that you'd like to know a little bit more about, this would be a brilliant thing to hear from you, and we would like you to raise your questions through the chat, through the Q&A, or by raising your hand. So, I think that's enough from me. I would like to introduce Georgina Craig from ELC, who will take us through her award-winning, well, yes, let's call all these presentations are winners because they were shortlisted in the PEN Awards. So, Georgina, I'd like to hand over to you to explain what you were doing in terms of commissioning for patient experience.
Hi everybody, I'm Georgina Craig. I'm the National Director of something called the ELC Programme, which is a social enterprise that seeks to spread and embed person-centred management processes. And we've been working over the last couple of years with Slough CCG to help them to make their commissioning more person-centred, and this culminated in a PEN Award submission last year, where we had the opportunity to kind of reflect on everything that we'd done together over several years, which was actually quite a lot. And the slides that I was going to show you were talking about a number of different initiatives that we did with Slough, because Slough really wanted to make person-centred commissioning the way it does things around here. And so over the course of the time that we've been working together, we've applied experience-led commissioning to the to review a significant review of maternity work, which was a big issue in Slough, because they have a hospital. Their local provider is Heatherwood and Wexham Park Hospital, which has been under quite significant scrutiny from CQC. And they also had they have a very complex local community in Slough. So they have a very 37 languages are spoken in Slough, and they have a very mixed group of people who they are supporting through the maternity journey, including a lot of women who actually don't speak English. So they have a lot of challenges. They have a very high cesarean rate as well, and so there's been a lot of pressure on local maternity services. They also wanted to complete a bid for the Prime Minister's Challenge Fund as one of the Wave 1 sites. And they decided that they wanted to do that by actually listening to patients and understanding what matters to patients, rather than just the GPs deciding what should be included in their PMCF bid. And finally, it was around the time of the call to action, the various different call to actions, and they wanted to build on the submission for the PMCF and put in develop their 5-year strategy and their primary care strategy by working very closely with and co-designing care with patients. So I'm going to tell you briefly about each of these different things and some of the changes that came out of it, but also some of the things that we learnt by listening to people. And from my point of view, working as a sort of commissioning support organisation, I think that people really underestimate the power of deeply understanding what matters to people from a commissioning point of view. We tend to think that it's all about services, but actually the only thing that really matters to people is their lives and what happens in their lives. And the services we deliver, the contracts that we set, the outcomes that we measure should all be really moving towards that aim of improving people's lives. So I think it's been a real journey for Slough to really appreciate the difference it makes when you really deeply understand what matters to people. So in the maternity work, we did this work very quickly. We started it in December, which is obviously not necessarily the best time of the year to be doing work, as we all know. But actually, you know, babies are born every day of the week, so it doesn't really matter from a maternity point of view. We spent quite a lot of the Christmas holidays in talking to women and staff in the hospital and into January, and over a period of about 6 weeks, we spoke to 250 women, their partners, and the frontline teams who care for them, and that was everybody from GPs, health visitors, midwives, consultants, anaesthetists, obstetricians, everybody. The impact that having really deep insight into what mattered to both staff and to patients was that the outcomes that were included within the contracts for maternity services became more focused on being family-centred and changing the focus away from service and more towards those quality measures. A really interesting finding from the work was that what women said was, I really wish that the community team who follow me up after the hospital know what has happened to me. And staff felt this was really important too. And they even talked, when I remember very clearly one health visitor talking about the fact that she had gone to a woman's house and she didn't know that the baby had actually died, and that and she was faced then with obviously a mum who was very upset, and she was unprepared for that situation. So the fact that there was a need for a much better way of passing on information is not unusual. But what happened as a result of the co-design is that what women said was, we would like to tell our story in our own words. And so the CCG set about responding by embedding something called a narrative-based discharge process. So the idea behind that is that the women actually write their story or record their story, and that gets passed on to the community midwives when they leave the hospital. And as a result of that, it helps them to process some of the issues that they've had to deal with, which is good for their emotional recovery. The other thing that we found was that many women had undergone an unexpected event during their pregnancy or birth, and sometimes those events were life-threatening, and sometimes those events were not life-threatening or regarded as particularly important clinically, but even so, the woman had experienced significant trauma as a result of that event happening. So a good example of this was third-degree tears, vaginal tears, which left the woman very immobile and losing a lot of confidence about leaving the house, but actually was not really recognised as professionals as something clinically significant or important. And so hearing the woman's story really helped the clinicians to really reassess whether or not this was an important issue, and recognise the impact on people. The second thing was that we found that actually women were suffering from post-traumatic stress disorder after an unexpected event, rather than postnatal depression. And the clinical psychologist who we were working with in the hospital on this program shared with us that actually that doesn't manifest itself until 3 months after the event happens. And so in terms of sort of supporting women, by that point actually the midwives are no longer with the woman, and even the health visitors may not be so closely supporting the woman anymore. And so there was a lot of women who were really struggling with emotional well-being issues, and perhaps almost didn't really recognise what was going on. So we were able to highlight that through this work, and look at how we could respond better. So moving on, very quickly, I'm guessing that my time is growing a little short, so I'll focus mainly on this second one in terms of finishing off today. Those of you who are not aware of the Prime Minister's Challenge Fund will know, or may not know, that it's all about improving access. And I think one of the things we have to remember sometimes is that politicians are also commissioners, because actually the Prime Minister has decided that between 8 and 7 days a week that GPs surgeries should be open, but actually that's not really what patients tell us matters to them around their GP service and access. So we're kind of the PMCF bids are all fighting against a politician's statement of what matters to a politician as opposed to what matters to patients, and that's an interesting dynamic we have to deal with. So what we found out when we worked with the CCG to help them to understand what to put into the PMCF bid was that for people it was important. Access was of course important, but actually what mattered as much was improving the quality of the conversation between the patient and the GP. And so the bid that we put together focused equally on that as it did on improving access. The CCG and the GPs won £2.9 million from that bid, and perhaps more exciting for us certainly was the fact that they got national recognition that of all the PMCF bids that were submitted, theirs was the only bid that had actually involved the community in co-designing the PMCF solutions that were in the bid. So we've been working with them over the last year to actually implement some of the things that were included in that bid. And unfortunately, I haven't got time to go into them all, but some interesting work we've been doing around why people frequently attend GP surgeries and the impact that has on staff, and also changing the conversation between GPs and patients so they can actually really understand what each other is saying, as patients fed back that GPs' language was often like a foreign language for them. So I can see I need to move on now, and I'm happy to take any questions later.
Brilliant. Thank you so much, and really interesting to hear much more around the work that you've been doing with Slough and the impact it's been having. With no more ado, may I hand over to Jenny, who will talk to us about the work that they've been doing with complaints and concerns. And don't forget, if you want to tweet, her details are at the bottom left of this slide. Jenny, I'm going to hand over to you.
Fabulous, thank you very much, and hello everyone from a very sunny Lincolnshire, which is really nice. Yeah, thanks for inviting us today. I'm going to take you through the work that we've been doing around complaints and raising complaints and concerns. It is a whistle stop in 10 minutes, but I hope I can give you a flavour of the work we've been doing. Essentially on slide 2, if somebody can move them forward then, we were one of the 11 first KEO trusts, which is not the best mantle to have, but my slide shows an extract from the report from our KEO review, which was really damning about our complaints process, and ultimately that it was not fit for purpose. A very clear direction that we needed to sort this out as soon as possible. I was given the task, and I took it gladly, because at the time complaints and concerns sat within the risk department, which I thought was very odd, and being new to ULHT, was very keen to get it into the patient experience portfolio. So the first thing that I did was, moving on to slide 3, was that we had a listening event where we invited some of our past complainants, and they were, some of them were cherry-picked as being our most dissatisfied and most vocally dissatisfied ex-complainants that had been through our complaints process, but also some that were currently had complaints in the system. It was probably the hardest patient forum listening event I've ever been to in my career, and I've been to a few. It was facilitated by the Patient Association so that we could be completely independent, and they held no bones. They didn't hold back at all in terms of telling us just how awful our complaints process was, and you can see some of the headline messages that they gave to us. Alongside this, we then held did a similar event with our staff, and we held across, we're a huge trust, we've got 3 main hospitals, but also work out of a further 3 community hospitals. So we ran a range of staff workshops and went to various forums and asked the same sort of questions. And no one was surprised really that KEO had slammed our process quite as vehemently as they had. And if you look at my next slide, you can see that what the staff was saying was a mirror image of what our patients were saying. So they felt absolutely solidly that there was no accountability, there was no ownership, that the process wasn't working, and ultimately people were using words like it was broken. So designing from scratch, what we needed to do was triangulate everything that our patients had told us with what our staff had told us against the national reports and the national best practice. And clearly we had a wealth of this because we had the Francis report, and we were lucky that we were holding these events and this review in sort of October, November of 2013. So the ink was still wet on the Clwyd report as well. So we were able to design our process, which is a 5-step process that we called See It My Way, knowing that it encompassed the most contemporary best practice and guidance. 5 steps to this, which I'll take you through briefly. First off, in terms of putting things right, when we were looking at concerns, staff just were not empowered, they didn't feel able or confident to deal with things. Shockingly, we had no PAL service. If you weren't all on mute, I'm sure you're all sort of really sort of like sighing with shock, but there was no PAL service, so very quickly we introduced a PAL service on each site. There was no openness or transparency, there was no duty of candour in terms of complaints, and staff were not listening to what patients were saying. There was certainly no learning and sharing. We introduced our PALS teams, our PALS services on each of the 3 main sites, and we had a central complaints team at the time sitting within the Lincoln County Hospital site, which were very removed from our other 2 main hospitals and certainly our satellite hospitals. And so we went through some quite significant organisational change to introduce site-based teams for complaints and PALS. Patient representatives who'd been at the listening event were directly involved in all stages of recruitment. So we held an assessment centre, and we also had them on our formal interview panels. And we opened up the way people could access us. So through the web, through Twitter, Facebook, email, as well as via sort of the usual routes of letters and emails. Whereas previously people had just been told, well, you need to put it in writing. So, you know, huge changes there. And as Ruth mentioned earlier, we started all this with the board. The board were phenomenal because we were really looking at some radical changes in terms of ownership and leading on complaints. When we come to process and response, one of the big issues we had, for example, was if a complaint came in that related just to medical practice and referred to a consultant's care or medical care, the consultant would very purposefully hand that over to either a business manager or a matron to investigate or respond. That no longer happens. We have ownership at site level, so when a call initially comes in, within 6 days of receipt of that call, of that complaint, this is in addition to the usual 3-day formal acknowledgement. A very senior manager, so either a deputy director, clinical director, head of nursing or senior business manager, calls that complainant. And in 90% of cases, we actually do get through to the complainant. And they apologise for the fact that they've had to make a complaint. Basically what we're saying in that is acknowledging receipt, but we're also explaining the next step. So we are the ones, that senior site lead, that are agreeing the complaint plan with the complainant. We're telling them who will be case manager, and we agree a time frame, and we explain to them how we will retain oversight for that. And when we've evaluated this has been probably one of the single most valued elements within our new process, and was something that our patient representatives at our listening event were very keen to have in place. And so a clinical director will be phoning up and saying that Mr. So-and-so or Dr. So-and-so will be investigating the complaint. Now clearly, writing a complaint response is actually a real skill. And in terms of turning this around, where my medical colleagues, I'm very open with them, they are fabulous at writing a chronology of events and fabulous at saying what they did, but not fabulous at answering the questions that complainants have raised. And I thought, you know, it's going to be a nightmare to actually get them to creatively manage and respond to a complaint. So what we've designed is a complete new documentation. And we've created an investigation grid, which is in my slide 10 when you come to see that. And essentially this is a table. The first column is populated by the complaints team, who put into each of the cell of that column what the concerns have been. It's very clear then that when this grid is sent out to everybody who is participating and contributing to the complaint, that they need to respond to each and every question. It forces them to answer the question, so they complete it within that grid. It also forces them then to consider the learning and action related to that question and that concern that has been raised. These are all then returned, and the complaints team merge them into one final completed investigation grid. And rather radically, this is then sent to the complainant with a copy of an overarching response letter from the executive. That final column in terms of actions and learning is then lifted and included in our change register, so we can track completion of the complaint. And on the following slide you can see an example, an anonymised example of one that's been completed. We've developed a change register. As I say, we lift those learning and actions and we track those and sign them off. And from the new year, because this has still been evolving in terms of logistics, in the new year we will formally write to complainants once those actions have been signed off to close the loop and say, you know, we promised we'd do X, well, we've done it, and here's the evidence, or here's an overview. We've also introduced a peer review panel, which again is made up of patient reps who've been involved right from the start, and Healthwatch and Power. And we meet quarterly. They select a random selection of complaints, and they review them from start to finish against our policy and against our key principles. And they have really noticed a difference. And we built in assurance, which we didn't have before, so our executives had no oversight of complaints. They weren't seeing them, they weren't seeing the sign-off. I know this is shocking and hard to believe, but also now we have dashboards that go to business unit level, consultant level, not only in terms of numbers, but in terms of responsiveness and quality, and a whole range of reports that we include with this. Here's just a very simple snapshot of our change register and the process of how this is then sent around to people. We weren't alerting in terms of number of complaints, but we were seriously alerting in terms of complaints that were unresolved. So if you can see on the graph on the left-hand side there, the amount that were bouncing back, and once we introduced executive sign-off, the executives were then saying, you know, this isn't good enough, or we had the assurance at site level, and that sort of trend significantly dropped off. What we did, however, have was a huge number of historical complaints in the system. I mean, if there was ever a time to introduce transformational change and a radical overhaul, this was not the time to do it, which is why we were exceptionally proud of the work that we've done and to have been selected as a finalist at the PEN Awards. And as you can see, we've had a concerted effort at clearing the backlog, but clearing them in terms of qualitatively, and we are on trend to have completed and completely cleared our historical backlog by the end of November, which, you know, we were touching 400 complaints in the system now, which was shameful, absolutely shameful. And so, you know, I really want to push that from start to finish, this was driven by our patients, and not only in terms of design, but in recruitment, and they are overseeing us really, that we are promising what we said that we would do, and they're, you know, they're tough, and they won't sort of miss anything, so they've been fabulous allies along the way. We've built all our expectations and our principles into our patient experience training, and really major in terms of perception, empathy and expectations, so that, you know, people can't turn around and say this complaint is invalid because actually this was that person's experience, and you can't deny that, you know, that this is what they said has happened under your care. So really sort of driving ownership. And as I say, you know, we've done this in an area or on sort of ground that was really struggling to begin with. So, you know, to see this level of change and engagement has just been phenomenal. So, and it has become part now of business as usual. So, yeah, thank you very much. I wasn't keeping an eye on the clock, so I hope I haven't driven too far into anybody else's time frame, and as I said, very happy to take questions at the end.
Jenny, thank you so much, and really great to hear just such an honest presentation, and a problem tackled so very thoroughly. So thank you for sharing that, and I think there's some great insight there around a really robust complaint procedure that's now in place. We are really tight on time today. I'm going to propose, if it's okay with everyone, that we run over to 5 minutes past 12 to give both Amy and Heather their full time. So Amy, I would like to hand over to you to talk us through. I'm hoping you can hear us and we can hear you. Brilliant. That's a great start. So I'm going to hand over to you. So let me know if on chat, anyone, if you think you can't stay on for 5 minutes after 12 o'clock. I've sent a message out around questions. I think we'll probably need to tackle those offline now. But Amy, over to you.
Thank you. The slides haven't come up on my end, but maybe they just take a second. I'm actually not talking about why we were shortlisted today. We were shortlisted based on an app that we've been working with Captive Health on, which we are just about fully implemented, which we're very proud of. We've added a few extra modules to it, which means that all our patient leaflets and video library is now in people's pockets, and we also have the feedback facility enhanced on it, which allows people to leave a text, complete a friends and family survey, or leave video feedback through the app, which is really quite exciting. But Andrew gave me the opportunity today, rather than talk about that, to talk about something else that was quite exciting that I did in the spring, which was to attend the Cleveland Clinic Conference in America for the Patient Experience Summit, about 2,000 attendees, which incidentally is a free conference to attend for international people. If you want to be looking at that for your next trip, you just have to pay for getting there and your accommodation, obviously. But while I was there, and you can hear from my accent that I'm from those parts, I promised my trust that I'd take in a few other activities while I was there. So I visited, in effect, about 17 different hospitals, visiting their patient experience departments in addition to going to the conference. And what I wanted to share with you today was just a true whistle-stop tour over some of the things that I picked up on that you might be interested to get more information on, and then I've provided you with my entire slide deck, because so many things come through better in pictures than text anyway, but I'd be very happy to talk with you more about those later. I'm still not seeing the slides. Am I the only person in that boat?
No, I think there's just a bit of a slow upload at the moment. They're not coming through. So.
Well, basically, what I wanted to, I've got some images of some of the hospitals that I went to, but one of the States in lots of ways is a few years ahead on so many things, mainly because patient experience is incentivized with money for every hospital. So basically your patient experience scores, what we would essentially our friends and family score, they do something different. They have a much bigger survey, almost like a picker type survey that they do monthly. And they get rewarded by reductions in their insurance premiums based on those scores nationally. So there's incentives straight away, cash incentive, to make sure that you're getting high patient experience scores. And it's things around food and quiet at night and communication and coordination of care, and all of those really, really difficult nuts to crack sometimes, because in the UK we do that based on some sense of altruism that we hope that our executives smile upon, but ultimately it comes down to a cash envelope, which isn't always there for us. So so basically, the premise of family and patient-centered care is what's hijacked the patient experience journey there. And I say hijacked in that they don't even call it patient experience in some respects. Departments have transformed their ethos to being called family and patient-centered care or departments of service excellence. So they don't, patient experience is sort of almost a last-year expression. Family and patient-centered care, you probably know, is about treating the entire family as part of the care team, and therefore extending all the courtesies of how you would treat a colleague professionally. You'd extend that to the family members who are all on your team to try to get that patient, try to get that parent better and out of your building, out of your site. And so therefore wards are set up to have family spaces, family kitchens, rest and relaxation spaces for the entire family, and that is, that's just the way it is. You don't have to fight with the states about that. You don't have to fight with anyone. That is that everyone's sort of signed up to that principle. Is it up for people now? Yes. Okay, brilliant. So some of the initial slides really are around the Cleveland Clinic. Patients First is on the walls. Quotes are everywhere. Messaging about what patients should be able to expect are everywhere. And so I've put a few of these in here, which I think is, we certainly in our trust, we put our values on the wall, but we don't put on the wall necessarily what the simple things that we know that we expect our staff to do that sort of manage the expectations of the patients as well. It keeps people accountable. I'm just going to flip through here. I gave you, like I said, I gave you everything because I don't know what would be most interesting to you. But, you know, here we see lots of the hospital rooms are sort of set up like hotel rooms, and you can see here that the housekeeping department takes great pride in the service that they provide, and they leave cards in all the rooms. Something else I wanted to, I'm just going to skip ahead here to some interesting work on rounding. So it's a bit slow on the internet. Here we go. So rounding is grounding, and one of the standards that all hospitals are measured on is hourly rounding. Did my nurse round on me hourly? So that's a national standard. Every hospital asks that question, which is really you know, quite amazing. And it's based on the CLEAR research, and I have in the next 2 slides here. This shows a hospital where a patient scores said, you can see the high scores. When a nurse rounds hourly, everything about that care is good. The pain was less, the food tastes better, the medication was delivered on time, the nurse communication was good, the room was cleaner. Everything is good about care when nurses round hourly. And the next slide shows the opposite. When scores across hospitals say that the nurse never visited hourly, then you've got everything else going low. So I brought this back to our trust. You know, we really, if we want to focus on one quick win, and because it's not a quick win actually to get hourly rounding in place, but you want to have something that affects across the board a patient's perception of their experience while they're inpatients, we need to get our rounding more systematized and hold our clinical staff accountable to the rounding. So I wanted to particularly share that with you today. There's quite a lot here on, this one I just sort of laughed. You know, this was actually in a hospital asking if people wanted a prayer said for them while they were there. That was in the main reception in Ohio. Lots of signage I took pictures of. Wireless telemetry is standard in the maternity wards, and we're forever trying to agree on what types of signboards ought to go in our trust, so I took pictures of loads of those just to give you a sense of the variety. Something else I just wanted to say in the few minutes I have left is to talk about one really dynamic way that an organization made food a priority. And basically what they did, I need to figure out where in the slide deck it is, but with no additional cost to their regularly run service, they transformed their food service from being kind of the assembly line that is in cafeteria style that they have in most restaurants to room service. And the investment that the organization needed to make was simply in the equipment that they had in the kitchen. But all that they did was redeploy the staff into new roles of being wait staff. So I have loads of pictures in this deck about that journey, about that, how that hospital, what that hospital took in making that happen. But that is now being rolled out across many organizations because food quality is a big factor in patient experience for particularly longer stays. So I'm seeing if I can get to that point here. Oh, these are really just to make you giggle a little bit. Does anyone know what this might be? Can you see this slide? Oh, you can't talk to me, can you? Anyway, that's a circumcision station. And if one isn't enough, there's 3 here. So there you go. That's the Americans for you. But if I fly through here, you'll see that there's some stuff on here about I can't get it. I think it's too slow, so I think I'm just going to leave it at that. The final kind of 100 slides in here are all, and the reason why that they sent me on this trip was because we're building a new hospital. So I was looking at hospitals particularly that had used a lot of patient co-design to develop really high standard types of patient-centered care wards within their hospitals. So I have loads and loads of pictures, and I have some notes in the slide deck as well explaining some of that. And I went to several talks at the Cleveland Clinic conference done by architects who had really have some very interesting ideas about the use of light and space and you know, corridors that are patient-facing, and then sort of the off-stage corridors that are staff-facing, because there's all sort of new science to how you should use space and light for maximizing health. So I brought all that back with me, and I know that we all have various guises of building projects in our future in the NHS, so I thought that might be useful for you. I'm going to leave it there for today because we're behind schedule, but if you have any other questions, you know, feel free to, I'm happy to talk to you, you know, offline as well.
Super, thank you, Amy. Interesting and you know, great insight. Thank you for sharing that. I've been watching rounding and the way it's being taken up in the UK with interest, so interesting to see how embedded it is in the States. Thank you very much for sharing. Heather, if I can hand over to you to finish today's set of speakers, to introduce us to your Transgender Awareness Project, which I'm really looking forward to hearing about. So thank you, Heather.
Okay.
Thank you.
To give you a little bit of background about me, so my name is Heather Ramesser. I work for Public Health Wales as the lead screening engagement specialist. So Public Health Wales is an NHS trust that runs across the whole of Wales, and part of one of the directorates that I work for actually looks at the national screening programmes. So you can see from that slide, hopefully you can all see that, the range of different programmes that we actually cover within that particular division. So the purpose of the screening engagement team, which is the team that I lead, is to do an awful lot of work with our populations. So you can see there from the slide that we do a lot of partnership working. The range of work that we're involved with would demand that, given that there's only 7 of us across Wales, that we need to do a lot of working with our partners. We're responsible for public engagement, service user experience, service improvement, public information development, education and training. We also have under our remit an awful lot around equality and reducing inequalities in health too. So a bit of a broad spectrum really. So ordinarily I'd tell you what screening is, but I think because we are short of time, I'm going to whiz through the next couple of slides to get to the juicy bits of the project really. But there is a definition of what screening is there for you all to see and have a look at. And also there's some information about the different screening programs, because this project focuses primarily on the adult screening programs. So that's, as you can see from the slide there, that includes the breast, cervical, bowel screening, and a new screening program called the Wales Abdominal Aortic Aneurysm Screening Program. So those are the focuses of those are the programs that we focus this project around. So what we do know about screening is it's about informed choice, and basically people should be given the right information so that they can make an informed choice as to whether to take part in screening or not. So that's the formality out of the way, and really then I'm going to bring you to the project. So with this particular project, the Trans Awareness Project started, it's going to be about 3 years ago in December. So it seems like a long time to me, but I talk to our trans partners and they tell me that's a relatively short time. And basically, we've been working with this particular community for all of that time to try and move things forward, because they actually came to us and said to us, look, you know, we have some issues really in terms of accessing your services. And basically, is there an opportunity that we could work together? So in actual fact, what I did was I invited them to come to a particular meeting that we have. It was a team meeting, and to have a discussion really about how we could actually do anything jointly, if at all possible. And at the meeting, I was only expecting one person, but in fact, there were 3 people who came, a member from FTM Wales, a person from the Centre for Equality and Human Rights, and actually somebody who came from the Unique Transgender Network. And basically, they were involved in that programme of work right from the beginning. Some of the things that they told us were that actually communication was an issue. Transgender service users generally don't communicate by letter. They tend to be quite a hidden community, and actually what they use are communication methods like social media. So us writing out to everybody really didn't hit it. There was a huge anxiety around education, and that wasn't just education of our staff, it was actually from people from the trans community, professionals, and generally their experience of health was quite poor. So they'd obviously experienced some discrimination, they'd experienced poor pathways of care, and generally didn't really have great confidence in health generally. Also, the information that we were putting out for screening was very binary in that it was for either for men or for women. And actually, we had no specific trans information available to service users. And finally, the engagement between trans service users and screening was poor. I've been in post quite a long time, and actually, you know, we've tried to obviously engage with this particular community, probably rather unsuccessfully in the past because it's been done on an ad hoc basis. This gave us an opportunity to look at trying to do something together in a more formal, structured process. So following that initial meeting, we drew up an action plan of the things that we could do. So it was, you know, the fact that we couldn't change our systems; those were fixed, and that was what we had to deal with. But it was about finding a way forward in some of the key areas that they had suggested to us were a problem. So things around training and education, that was in our gift to change. The information development, that also was in our gift to change. We're an active engagement team, so there were opportunities there that we could link in with our partners to try and raise awareness and educate and inform. And there were other mechanisms that we could consider, you know, in terms of our websites that we could actually make a bit more trans-friendly, which currently, at that time, they weren't. The biggest problem I had was getting transgender on the agenda because actually, as we all know, our organisations have all differing priorities and, you know, obviously pressures that need to take priority. And actually that took a lot of skills from us really in terms of how we negotiated that and got it on the table and got it on the agenda. And I can safely say that 3 years on, transgender is very much on the agenda in screening, and in actual fact, you know, the service users we've been involved with have transformed the way that we sort of think here in terms of getting our standard operation procedures right, and they've been instrumental in doing that. They've also met with key staff. We've just delivered training to all of our staff within the division who have frontline service response, so they are much more trans aware. So it's been quite a journey really trying to make sure that this is something that we take seriously. So the training aspects, obviously we have met with different program leads within screening so that actually they could come to face with trans service users to identify and listen to what they're saying about their programs in terms of accessibility. And that was really, really quite interesting and a very useful piece of work actually, because looking at the key principles about broadening perspectives, sometimes we work in such a siloed way looking at our processes that we miss the bigger picture. So that was quite interesting. And then obviously we've looked at delivering some training to our frontline staff, and as I say, we've just completed the second round actually. We've got one more training session to go in November, and then we're complete and all our staff have had that training then. Information was a huge issue because what was highlighted very early on was the systems that we use to invite people for screening could potentially either include somebody who's trans where they don't need to be screened or exclude them when they do need to be screened. But actually nowhere on our information did it say so, and actually it was something that we hadn't really thought of. So this piece of work has been a phenomenal amount of work, but it's been fantastic in the same breath because actually now we have a dedicated resource for transgender service users which explains exactly what will happen, how our systems work, who is going to be called for screening, who isn't going to be called for screening. And actually it's, as an educational resource, it's something that has been reviewed as quite revolutionary in the trans world because it's the first piece of information for screening in the UK. So that we feel fantastically proud of, and it was co-produced, so it was something that obviously we did together from the outset, and actually we consulted with the trans community in the development of that. We've also developed some other additional information cards, which are discrete cards that we can give out at various location events, because obviously it needs to be discrete where people can access the information via the web. We've developed a set of frequently asked questions and some short educational films which we use around health education and training, both professional and service users. And we've also developed some, in conjunction with the trans community, some specific trans pages on our website. So no longer do we have that binary view of our website. We actually have specific information and a portal really where they can go for further information. And as I say, all of that has been done as a co-production approach really. So those are just some sort of screenshots really of some of the information that I've just described. And basically, in terms of engagement, this is an ongoing exercise. So when I ever do engagement work, it's never to do it in the short term. It's just, you know, it's something that has to be an ongoing commitment to a particular community. And this is no different to any other that we work with. So in actual fact, we have continued with our engagement with this community. And since the bullets that you can see on that slide, we've done a raft of different conferences, community networking events, you know, various. Last week I happened to go to one of the local networks to present the resources and explain how screening works. So that actually is ongoing, and I see that developing certainly over time. And hopefully by the end of this year we will have completed all of the community education as we intended to as part of the original action plan. The project was launched last year, 8th of October. We had the Deputy Health Minister who supported that project. I'm hoping that we will now begin to evaluate the leaflet. We're going to continue our community-based education, which will hopefully be finished by the end of the year. We're going to make sure that our website remains inclusive, and obviously we're asking other trans service users to work with us to obviously improve that, which is great because they are coming forward with great suggestions. And as I mentioned before, this is about a long-term, you know, a long-term project. It's not about quick fixes. And it's been great really to share this good practice with other organisations, because a lot of learning and a lot of links have been made, and that's happened as a result of this project. So I feel quite proud that we were able to facilitate that change. So are there any magic bullets? Well, I suppose really the big ones for me, I was quite interested to see all of the principles, winning principles, because they were all things that we would mirror. But actually hard work and commitment is the biggest one. Small steps, achievable goals. I think managing realistic expectation is quite crucial. Working together, so I hear people say that they co-produce, and when I look at their method of co-producing, it's probably not the same as mine. So actually true partnership working is what we're talking about here. Recognising difference, we're not all the same, and actually what we might provide as a service may not meet the needs of people that we are trying to access. And facing those challenges together. I know sometimes I hear people say about service user experience that actually it can be challenging because it's unrealistic what people want, but actually in my experience, if you handle it properly, actually it's really not, and it can be quite empowering. And I've taken this last 3 years as a real learning opportunity, as have the trans partners that I've worked with. And finally, I know it's a really quick whistle-top tour, but there's my contact details if you do need any further information, or, you know, as we said, we've run out of time today, but if there's any questions, I'm more than happy to answer them. Thank you.
Wonderful. Thank you so much, Heather, for sticking with us to the end. So just a quick wrap up. We are going to finish in the next minute, so conscious that people allowed an hour for this today, and with technology we've slightly overrun. So if you do have questions, please do let us know, and we absolutely will address those offline. But just as a quick recap, we started off with Georgina, who took us through the experience-led commissioning, and the particular nugget amongst the many that we heard was around the narrative-based discharge process, which I found really interesting, Georgina. Thank you for sharing that with us. Then Jenny stepped into the fray because we couldn't quite hear Amy at that point. Again, really interesting view of going from quite a damning picture to something that was much more proactive and is embedded across the organisation now. But again, a particular gem or nugget I took away from that is that writing a complaint letter is a skill, and I think it's hugely underestimated. So thank you, Jenny, for sharing with us. Then Amy took us through some experiences she's had in the States, and I found it fascinating to hear that it's not patient experience anymore, it's patient and family-centered care. You know, I might debate that, but we'll see where it goes in the UK. But it was great to have a reminder of the importance of intentional rounding as well. So thank you, Amy. And finally, finishing off with Heather today, who took us through the work that they're doing in Wales, and was really interesting to hear of how that engagement process works and how it started to become embedded across the organisation. And totally agree, I think there are quite a few definitions of co-design, co-creation, co-production, call it what you will, but actually not all of them are true co-production, where we really are involving all of the critical stakeholders. and I found your inclusivity and engagement fascinating. So thank you, Heather, for sharing that with us today. So on that note, we're going to close today's session. Don't forget it is recorded, so if you would like to have access to the slides, they will be available on the website. Massive thank you to PICA and the Institute for supporting us today, and to you for joining us, and to all of our speakers, thank you. Have a great rest of the day. Goodbye for now.